Ambulatory site staff safety from workplace violence is our episode topic. Rejoining us as guest is Dave Corbin, a certified healthcare protection administrator, certified protection professional, and a healthcare violence and principal security consultant at Dynamic Security Strategies. Dave is the author of the Community Care Site Security Field Manual. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Dave, welcome back.
Thank you. Thanks for having me again.
All right, today we're going to talk about ambulatory site staff safety. And what exactly are we talking about when we're using the terms community care sites?
Community care sites are exactly what you just mentioned. Those are the ambulatory sites, the physician offices, urgent care clinics, outpatient surgical centers, any facility or service that's located outside of the footprint of your hospital campus. And community care sites, if you're in healthcare, you know that they're expanding very quickly as healthcare organizations try to put care closer to where people live to serve them better. It also helps to feed patients into the system because those nodes are out in the community. So you're helping the community and helping the overall organization at the same time. And it also reduces that burden on the actual hospital campus trying to have all those services under one roof. So that's what I'm talking about when I'm talking about community care sites. Those are those rapidly expanding physician offices, specialty practices, urgent care clinics, even like I've seen PT clinics, standalone PT clinics. And sometimes in some areas that can include your standalone emergency departments as well.
What prompted you to write this field manual on this topic?
I had written a manual previously called Patient Violence Prevention and Mitigation. And I actually went back to the people who bought that book and I said, what should my next field manual be on? And the majority of the responses I got said, there's a gap here around community care sites and how we should protect them and what are the best practices. So that's pulled my readers of my previous book. And also from my own experience, I had been seeing that from my clients who were reaching out and wanting risk assessment of their community care sites. A couple of them reached out. I said, well, how many sites do you have? They're like 300. And I was like, okay, well, I'm not going to go to all 300 sites and you probably don't want to pay me to go to all 300 sites. So let's pick a representative sample for us to look at. And that might be 10, 15, 20, whatever, but I've never done more than 20. Each kind of area, rural area, urban area, give me a specialty one, give me a physician's office, give me a representative sample. And then what I'll do is go out and look at each place and then try to come up with some level of overall baseline security standards to use across all the sites, right? And with the idea that I know you're not going to get all the sites at baseline in a year, but this is something to strive towards. And when you build a new one, here's what should be in it. And that's what a lot of organizations are looking for is what should we be doing with all these sites and what's the expectation of security? What level should it be at? There's a few organizations that I have encountered where they have a dedicated team of folks, small team, that is designated to take care of those sites. Or they even have, I've seen one system in particular recently that hired a director level person, security director, to oversee all their sites. Now they had hundreds of sites all over the place. So they hired somebody just for that, which I think is a great idea, but not something that's within the reach of many organizations who are struggling to keep the lights on. But certainly a lot of these community care sites are on their own when it comes to security is what I'm trying to say. They're relying on 911 as their security. And so that's why I wrote that manual, because it's a unique type of site, doesn't get a lot of attention until something bad happens. And then At that point, you're trying to patch things together and do the best you can. They're not great at reporting when things happen until something tips the scale and there's a serious incident. And then they say, this has been going on for months, and then finally blew up today.
Who is the intended audience for the field manual?
I wrote it so that anyone can pick it up and use it and find it useful. I didn't write it for security leaders or staff in particular. I wrote it for a practice manager can pick it up. A risk manager can pick it up. COO can pick it up. Anyone who has an interest in improving the security of their community care site. And it's really written at that level where if you don't have any security background and you pick this up, it'll be useful to you still. And there is a section of it that talks about if you're going to set up your own portion of the security department that is focused on this, here's how to do it. And that is written a bit more for that audience. But for the rest of the manual, it's very much written for anyone to pick it up. And the inspiration for the field manual type of format was the Army field manuals. I was in the Army Reserves earlier in my career, and I like how they were written that anybody could pick it up, right? From a private to a general. And if you have no experience with this, it'll guide you through what you need to do, what you need to know. There's no fluff in there. It's very much exactly what you need to know and how to do it, and written for any level. So that was the inspiration for that type of format, and to get that into as many hands as I can.
My knowledge of ambulatory sites, community care sites is really limited to my experience as a patient or as a family member of someone who is a patient. Just curious, what type of security challenges exist in these community care sites?
I think the good news is that most of these sites, the extent of their exposure to violence is mostly verbal, right? Just people getting loud, people making threats. There's not often physical violence happening at these sites. But so one of the challenges is really the lack of knowledge oftentimes of what to do when somebody makes a threat, when somebody's causing a problem. And oftentimes I see the source of that being frustration with the wait time, right? They're just upset. What I've started to see too is that in order to clear the waiting room, they'll put somebody in an exam room, and then they're sitting in there waiting, which I think is worse, because now you don't have access. The TV's not there.
But they're forgotten about them.
And you're in a room with no windows, and it's dead quiet, or you can hear the physician or NP in the next room like laughing or something like that. You know what I mean? There's an expectation when you go in the exam room that someone's coming soon. You get your vitals, that person leaves, and the doctor will be right. And then nothing, right? And then you're there for minutes. Who wouldn't get upset with that? There's no communication. There's no light. You don't know what is going on, right? And there's nobody to ask. And if you walk outside the room, you might be in a long hallway somewhere. There's nobody around. So people are getting upset in the waiting area, but then they're like, oh, let's put you in an exam room. And then they're getting upset in there. So I think wait time is definitely an issue, especially in urgent care settings where people are there because they see urgent and they think they might be seeing quicker, just like the emergency room where you go. Yeah. So that's one of the issues. The other issue is around just med-seeking patients, doctor shopping sometimes, but they come out with the expectation they're going to walk out with a script, and then they don't get it. And those folks who are med-seeking are some of the more problematic folks. They will not take no for an answer, and they will refuse to leave. I heard of one where the person wouldn't leave, and they finally left and went out in front of the urgent care clinic and sat on the hood of their car in front and stared in the window until they had to call the police. Yeah. So med-seeking patients are an issue. I also think the location of some of these community care clinics, because they're meant to be out in the community, they can be in a high crime area. And what I find is the more urban the area, the further away the parking is, because they have to save that parking for the patients. The staff are walking blocks to go to their parking lot at night in a sketchy area. You also have just exposure to community crime. I remember I had one community care clinic. This is more rare, but just give you an example of things that they have to think about in a higher crime area. This is a high gun crime area too. Somebody stumbled into pediatric practice one afternoon who had been stabbed, and he's bleeding heavily, and stumbled into the waiting area looking for help because he'd been stabbed like right nearby. And when you're desperate for help, it's clearly not a hospital, but you're looking for help. You're not going to say, oh, that's a pediatric clinic. No, I need help right now. And he stumbled in and they had to think quickly. They're like, oh, what if they started helping him? Somebody needs to lock the door. What if the person who stabbed him just saw him come in here? We're at risk. And so it made them really think differently about if this happens again, to have a procedure kind of thing. So I think that the things that people have to worry about are in the community care setting are frustrated patients, verbal aggression, med seeking, people just overly demanding patients who won't leave until they get what they want. Or one of the issues I see oftentimes is a lack of access control between the waiting area and the treatment area. And there's usually one or two doors that lead from the waiting area to the treatment area. And I'll see the door propped open or it doesn't have a lock on it. And what happens is John Smith wants to see his doctor and they're like, he's busy. I need to see him right now, and walks right in the back. Now try to get rid of that guy, right? Because he's already in the back. He's walking around. Now you have an angry patient intent on seeing his doctor. And this could be a situation where, hey, I've been calling for the last 3 days. I need a script refilled, or why can't I get an appointment? And now I try to remove that person. It's going to be very difficult. So I often see there's a lack of access control. And there was a recent consultation I did for a client where I asked them how they were feeling about security. They said, ever since they locked that door to the back, we felt 100 times safer. And all it took was a locked door because they felt like they had nothing to protect them in the back if somebody came in. And they did have people come in and demand, and they had unhoused people coming in and refusing to leave. And that the locked door made all the difference. What I often find is the little things that are forgotten about in the ambulatory setting that can really expose the staff and the site to risk unnecessary.
Are there certain strategies or tactics that are more important than others for community care sites? You talked about parking, for example,
Yes.
as one thing, which frankly, I would have not thought of. I would have thought about it for the hospital, but not. And it makes sense now that you brought that up. What other things that we really need to be thinking about for community care sites that may not apply in the hospital setting?
Sure. Knowing, first of all, getting to know your local law enforcement liaison and let them know that you're there, especially if it's a new site. But even if it's not, reaching out to local law enforcement, introducing yourself if you're the practice manager, let them know who you are, what kind of challenges. And if we call you, by the way, it'll probably be something pretty serious because we handle most things in-house. But make sure they're familiar with your site. Ask them to come by for a little tour so they can check it out. That can be helpful. Also, making sure your staff know how to call 911. And I know that sounds ridiculous. Well, you dial 911. And even though there have been laws passed that you have to have direct access to 911 and be able to dial it right on your phone from a commercial enterprise, sometimes that doesn't, you still have to dial 9 or you have to dial 8 first or something like that. So make sure they know how to dial 911. Do they need to get an outside line? And then what to say when they call. And I know that also sounds ridiculous, but what I find is that sometimes staff will call and play this situation down because they're afraid. So they'll say, what's this? And they're taking it down a notch. And I always tell them, don't sugarcoat anything. Tell them exactly what's happening. If you're afraid yourself, tell them you're afraid. If people in the waiting area are scared, tell them that. Relay the level of seriousness of the situation. And then the other piece is for the staff and leadership to understand what I call the safety from violence gap, which is the time that elapses between a violent incident starting and help arriving. That could be security if maybe you're on a large campus and you're outbuilding and it takes them 3 minutes, 4 minutes to get there. But if you're out in the community, you're relying on the police. So how long does it take for the police to get to you? And that should be something you figure out in advance, because even if you're in an urban area with a large police force, that does not mean that they're going to show up in 2 minutes. In fact, if it's a high crime area, there's studies a couple of years ago showing that the response time for priority 1 calls is actually increasing. So reaching out again to that law enforcement liaison, hey, how during peak times, what's the worst response time that you have? Like, what's the expectation we should have? Is it 10 minutes? Is it 5 minutes? I've talked to some folks out in rural areas where they're calling the highway patrol and it takes them 20 minutes. So how long do you have to bridge that gap? Do you have a secure room in the back that you can shelter in place in? But understanding the expectations from the police, and then letting your staff know what to expect, right? So they don't expect that the police are going to show up in 2 seconds. It's a big deal, and it's important to plan for in advance and for people to have the right expectations. So knowing how to leverage your local first responders, knowing what to expect, and having good access control between the waiting area and treatment area is huge. And really making sure your staff have the right training for the level of risk you face.
Any closing thoughts as we wrap up this episode?
It's important, if you're a practice manager, to regularly assess security risks in your setting. Get help early from your security department if you have one at a main campus. They are there to help, but they are stretched thin usually. So it's important to reach out early and proactively if you need help. Even if you want an assessment of your site, it's a good idea to reach out. And if you don't have that, you can reach out to local police, you can reach out to a security consultant and have somebody come out and look at your security.
Ambulatory-Site staff safety from workplace violence has been our episode topic. The Community Care Site Security Field Manual is available on Amazon. Dave Corbin, author of the Field Manual, thank you so much again for joining us today.
Thank you so much for having me. Appreciate it.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.